tumor growth, kidneys, liver, and pancreas. The webinar is being recorded. By participating today, you consent to the recording and future distribution. The camera setting by default has been turned off for all participants. We encourage you to participate on camera if you're comfortable doing so. If you do not wish to be on the recording, please keep your camera off throughout the presentation. I want to thank our presenting sponsor of the 2021 eWebinar series, Greenwich Biosciences, and our national support sponsors, UCB Inc. and Novartis. The Life Stages webinar series is sponsored by LivaNova, Lundbeck, Mallinckrodt, Neurelis, and Upshur Smith Laboratories. The TSC Alliance will host monthly educational webinars on a variety of TSC-related topics of interest, featuring known experts in the TSC community. These free one-hour presentations include an open question and answer period. The series is composed of educational webinars focusing on 4 topic areas: life stages of TSC, epilepsy, tumor growth, skin manifestations, and education, transition workshops, TSC-associated neuropsychiatric disorders, or TAND, and research updates and clinical trials. One additional housekeeping item before we get started. Everyone's microphones will be muted throughout the speaker presentations. Questions for the speakers can be submitted via the chat box and will be asked by the moderator at the end of the presentation. We'll do our best to answer as many questions as time allows. Dr. Lindsay Harshman is a pediatric nephrologist and the medical director of pediatric kidney transplant at the University of Iowa Stead Family Children's Hospital. She's also the co-director of the University of Iowa Tuberous Sclerosis Clinic. Dr. Harshman has an active NIH-funded research program that focuses on brain growth and development in pediatric chronic kidney disease patients. Dr. Harshman is quick to note that her biggest accomplishments is being a mom to 2 kids, Henry, age 7, and Margaret, age 4. I'll now turn it over to Dr. Harshman.
All right, let me share my screen and then we'll get started. Okay, perfect. Can everybody see my slide? Okay, perfect. Thanks, Julie. So thank you so much for having me today. I am a pediatric nephrologist at the University of Iowa. And as Julie mentioned, my clinical interests are focused to pediatric kidney transplant, and I'm the medical director of our program here. And I'm also the co-director of our tuberous sclerosis clinic here at the University of Iowa. I am so excited to talk to you all today. I was telling Julie earlier that I love this topic, and I love just the idea of being able to share this information as a community with the tuberous sclerosis patients and families that are here today. And so please feel free to stop me at any point in time if I'm going too fast. You can put a note in the chat. I'm happy to slow down, but I do get really excited about this topic. And so you're all forewarned. So that being said, today I'm going to just give you any conflict of interest that might be perceived for me today. As was mentioned, I do have funding through the NIDDK and specific to brain growth and development in pediatric chronic kidney disease. And the fun thing about the work that I do with my R01 is I actually get to be both a kidney doc and a neuroimager. So I actually do brain neuroimaging in chronic kidney disease. I have no other conflicts to disclose to you today, but I do want to be very transparent that I will discuss select medications and the use thereof in TSC-associated kidney disease. And so certainly you might hear me refer to specific medications along the way. I don't have any financial interest, and that doesn't necessarily reflect an endorsement, but again, just a understanding of the literature that's out there. Lastly, probably the most important thing, please discuss any therapy or considerations you have from this talk with your own TSC specialty team. I'll give you again the best evidence and data I have, but certainly if you have any questions, we'll talk about that at the end, but I also encourage you to discuss with your team too. So objectives today. We're going to really spend time talking quite a bit about kidney. Given my interest as a pediatric nephrologist, hopefully you aren't shocked. So we're going to describe the nature and natural history of kidney, liver, and pancreas tumors in TSC. I really want to help you understand the complications associated with kidney, liver, and panc tumors in TSC. And again, we'll spend probably the majority of the time focused on the kidney, since that's where the most literature is at. And then thirdly, we will describe the available evidence-based data as it goes to monitoring and treatment strategies for both kidney, liver, and pancreas tumors in this population. So I have 2 poll questions that I wanted to put out before we get started, and in part to help me learn about you. So the first question, again, help me understand who's here today. So select from the following choices, and we'll let this run for just a minute. Perfect, and it looks like poll number 2 shows up simultaneously. So also asking, how familiar are you with the guidelines for abdominal imaging and treatment of abdominal tumors in TSC? Okay, perfect. We've got 77% participation. You guys can do it. We can get to 100%. So it looks like the majority of you are parents of a patient with TSC, a few patients, one other physician, 2 other physicians, and others that are interested in the topic. And then the other question, which I think is going to be really helpful for me today to talk to you all, is how familiar are you about this topic? And I'm so excited to see that we have a pretty familiar crew. 38% of you say you're very familiar with this topic. 43%, yeah, kind of familiar, and then 20% not familiar at all. So that gives us an opportunity to really work from. So I'm going to end the poll, and then you can see the results with that. Okay. So let's dive into this today. So this is sort of the obligatory TSC in 1 slide or less. So TSC is an autosomal dominant disorder caused by mutations in either the TSC1 or TSC2 genes. And those encode 2 proteins, hamartin and tuberin, respectively. And so these proteins form this TSC complex, as you can see highlighted here. And within TSC, there is, unfortunately, that complex doesn't form well. These hamartin and tuberin negatively regulate this pathway called mTOR. And so when you don't have appropriate mTOR control, you can think of it like this. The TSC complex in all of us serves as a brake or a stop sign for your car. And really, again, it's serving to slow down the activity of the mTOR pathway. And so that mTOR pathway right here where the stop sign's at, it is super important for cell growth and metabolism. So if you don't have an appropriately formed TSC complex, there's nothing to slow down that TSC pathway. So again, think of the complex as a stop sign, and everything downstream, again, is this race car within the mTOR pathway. So you need a stop sign to get that Ferrari to stop. That way things don't get out of control. So TSC1 and TSC2 mutations, as I mentioned before, are the 2 mutations associated with tuberous sclerosis. And TSC2 mutations are generally thought to produce a more severe disease than TSC1 mutations. The clinical term that you would hear often is phenotype. It's a more severe phenotype. What does it look like? And certainly we do see potentially that TSC2 mutations.
You complained before that you don't know much about your disorder.
I never complained about it. I just commented about it.
Okay, fine.
TSC2 mutations are generally thought to produce a more severe disease than TSC1 mutations, such as kidney tumors like angiomyolipoma and renal cysts. And lastly, there's a higher risk for renal cell carcinoma, which is a specific type of kidney tumor associated with TSC2 mutations. So today, two things. I want you to really come away with, why is this important? Why is it important to have an understanding of abdominal tumors in TSC? I really hope to make it abundantly clear by the end of this talk that TSC-associated kidney disease is actually the most common cause of death in affected adults with tuberous sclerosis complex. So in addition to that, certainly I don't want anybody to pass away due to TSC-related kidney disease, but even more so, it's important that as a nephrologist, I help protect my patients' kidneys for the long haul, meaning that there is a risk for end-stage kidney disease or decline in kidney function that could eventually require transplant in a minority of individuals. The primary focus for today's talk will be within the kidney side, angiomyolipomas. And as we'll talk later, unfortunately, there's really not much literature on the topic of liver and pancreas tumors in TSC. So we're going to look at a lot of images today, and I tried to really highlight the images on these slides that I want you to see. So by the end of the talk, you will all be miniature radiologists and hopefully have a better understanding of what your doctor is talking about when you come to clinic. So when we talk about angiomyolipomas or AMLs, these belong to a family of tumors referred to as neoplasms of perivascular epithelioid differentiation. Say that fast twice or 3 times. And so you might also hear these referred to as PEComas. These tumors are really highly distributed around blood vessels and areas of vasculature. So the 2021 TSC surveillance and management recommendations really outline the role of angiomyolipoma in making the diagnosis of TSC. And again, many of you probably know this, but I want to make sure that we're all on the same page as we get started with this talk. A patient must have 2 or more angiomyolipomas in combination with major and minor features for a clinical diagnosis of TSC. So as you may know, a clinical diagnosis of TSC requires 2 major features or 1 major with 2 minor. So among the patients with tuberous sclerosis complex, their frequency and the size of these angiomyolipomas may increase with age. So it's really important that we talk a lot about today about routine surveillance. How do we actually detect these angiomyolipomas? And even more so, how do we detect that the kidneys themselves are staying healthy in addition to having the risk for kidney changes associated with tuberous sclerosis complex? So here I've shown and just highlighted some of the routine surveillance we're going to talk about today for kidneys, including kidney imaging. The preferred modality is magnetic resonance imaging, MRI. And we'll talk again throughout this discussion about the frequency with which MRI should be done. Certainly, your physician really should be looking at labs on a fairly frequent basis for the kidney. That includes kidney function numbers such as the creatinine, another number called a cystatin C, which is another marker of kidney function, and also looking at urine, the microscopic component, looking for blood in the urine and protein in the urine. That, in my opinion and how we practice in my clinic, I typically look annually to every 2 years if things are looking awesome. Every visit that you see a nephrologist, you should always have your blood pressure checked, and the nephrologist and their team really needs to be checking your blood pressure with a manual cuff rather than just the automated cuff every time, because the manual is going to give you a better picture of blood pressure. So let's dive into this a little bit more. As we mentioned, angiomyolipoma are these lesions that are a major diagnostic feature of TSC. I describe these to my patients as components of tissue that are fatty and vascular and muscle, all in the same abnormally grown area. Most of the time, these lesions are asymptomatic and they don't cause problems in childhood. By the age of 10, The data that we have suggests that the majority of pediatric patients with TSC will actually have one or more angiomyolipoma on imaging. And by the time you reach adulthood, up to 80% of adults will have one or more angiomyolipoma on imaging. The problem with angiomyolipoma is that they, by nature of the disease, they grow and they become symptomatic with time. And by symptomatic, what I mean is they actually, for some patients, can cause pain. They can actually start to bleed and leak. And we'll talk about that just here in a second. What does it mean for them to bleed or leak? The tumors themselves can actually be associated with risk for high blood pressure, which we just talked about needing to be checked regularly. And when these tumors form in the kidneys, they distort the normal tissue. They make the tissue potentially less effective, the kidney tissue. So then you have a risk for chronic kidney disease or decreased function over time. Certainly, again, this idea of a angiomyolipoma and the risk for rupture, I think is something that many are familiar with in this group. And there's a specific term that we get taught in medical school called Wunderlich syndrome, and it's a German word that basically means that you have a rupture of a piece of kidney tissue that silently bleeds until a point where someone has lost a lot of blood and becomes very, very sick. So that rupture risk is a significant cause of early death, and I would argue early preventable death in adulthood in our TSC population. Again, the spontaneous hemorrhage, that rupture, is at highest risk in either fast-growing tumors or tumors that are larger than 6 centimeters. So what does 6 centimeters look like? Here on this slide, you can see that a little chart that actually gives you a comparison of tumor sizes in parallel with common foods. This is a chart that actually came from the National Cancer Institute. And really, we talk about these treatment thresholds and risk for issues in parallel to size. And so when your doctor talks about, oh, well, you have an angiomyolipoma that's 3 to 4 centimeters in size, you could really be thinking about something that's about the size of a grape to maybe a small walnut. And then as we start talking about bigger tumors and these risks for rupture, you can quantify it even in a small lime or an egg, which actually, as you think about it in real space, becomes slightly terrifying, I can imagine, as a patient, and even more so, how do we take care of it? Appropriate abdominal imaging at the time of TSC diagnosis and every 3 years at a minimum going forward is really important for us to understand the nature and the rate of growth for these kidney tumors. And like I said on the last slide, it really making sure that in addition to imaging, your kidney team is really looking at the whole picture of the kidney, including labs and blood pressure. So again, I just want to pause here to emphasize that important role of routine clinical care. Sometimes it may feel like, your visit to your nephrologist is more of a social visit than anything. And look at your kidney pictures on MRI, but really any patient with tuberous sclerosis, your nephrologist should be thinking about the lifetime risk for kidney disease for your patient, your loved one, or yourself. Thinking that over time, there's that risk for chronic kidney disease where relative to your healthy peers or peers without kidney disease, your kidney function may be lower. And certainly there are things that we can do to minimize that risk for chronic kidney disease progression. And we'll talk about that in a couple slides ahead from here. What can we do to minimize that risk? So imaging in tuberous sclerosis complex. What really the preferred modality for imaging, as we talked about previously, is magnetic resonance imaging. And I have to give a really awesome shout out because children's hospitals are the coolest. And children's hospitals make things fun, right? And so this is an MRI scanner up here in the top left from our institution that's space themed, and it makes it more tolerable for kids to do imaging. And this is a CT scanner below it, a CAT scanner from Nicholas Children's Hospital, and you can see all the cool lights on that. The picture in the upper right hand corner is an ultrasound. And ultrasound is really probably, I would say, the third tier recommended imaging modality in tuberous sclerosis complex. So why do we even need to get pictures? As we mentioned earlier, with age and time, right? we see higher rates or higher numbers of angiomyolipoma develop. So there was a nice paper that was published that talked about looking over time in TSC and found that 60 patients, approximately 50% of boys in early childhood actually had angiomyolipomas. And then again, by the time they hit older than 10 years of age, over 60 to 70% of our patients may actually have an angiomyolipoma. That diagnosis really has to be made by imaging, and you need the appropriate imaging to do so. MRI is the imaging modality recommended by the Tuberous Sclerosis Alliance, and certainly the international consensus guidelines, and the minimum frequency is every 3 years. So let's talk about the use of these guidelines. They're very clear, very well published, and try to make it abundantly useful for people to know how often to image our patients, right? How often do we need to be looking for these angiomyolipomas? One of my colleagues and I wanted to dig into that question and say, well, we've got these guidelines. Are people actually following them? So we looked at data from commercially insured individuals between the years of 2003 and 2016 that had an actual diagnosis code of tuberous sclerosis. And patients less than 65 years of age were included. And at least half of the patients that we obtained or we were able to identify with a diagnosis of tuberous sclerosis were less than age 16 in the study. So a pretty robust pediatric population. Within this period of time, 2003 to 2016, what we actually found was kind of frustrating as a nephrologist. We saw that if you looked in relationship to sort of the 2012 guidelines that came out from the TSC, a consensus statement, really, there's still not as much MRI use as maybe we would have expected. There's still quite a bit of ultrasound use. There's still quite a bit of CT scan use. And MRI, even as of the latter half of the data we looked at, still hadn't quite caught up to the other modalities. So potentially suggesting that MRI is still potentially underutilized in our TSC population, despite the consensus recommendations. And then as we keep talking about every 3 years is the minimum time frame that we would really want to see somebody have imaging, and more frequently if you have development of a kidney tumor. And here what we found on this lower right corner, we looked at the frequency of kidney imaging, basically defined as the number of procedures with imaging per year. And so to have a yearly imaging rate, or actually even something once every 3 years, I should say, you'd have to have a number of 0.33 or greater, so 1 divided by 3. And what we found here again was that the imaging frequency within commercially insured individuals was significantly lower than is recommended by the consensus guidelines. And even in this population, where we could track diagnosis with billed procedure, we found that a pretty shocking number of patients actually had 0 kidney images done in this time frame we followed. So that being said, why do we need to get pictures? Are there risk factors for angiomyolipoma growth? And the data is actually fairly helpful on this question in really letting you know that there are probably 3 major risk factors for angiomyolipoma growth. Female sex, which then certainly ties into the risk with pregnancy and estrogen. And thirdly, the TSC2 gene diagnosis. Some data, some reports that are published actually are pretty explicit in saying that women with known renal angiomyolipomas should really be cautioned about the risk of excessive tumor growth during periods of pregnancy or hormonal changes. And that even in those periods, the frequency of imaging could actually need to be increased. So really, that just goes back to the idea that if something's changing in your life and you're a patient with TSC, you really need to be talking to your team and making sure that risk factors are minimized as much as possible for things like angiomyolipoma issue. So treatment. Let's go back to this figure from earlier, right? So we have the stop sign in the car, but our stop sign is just not talking to our speeding car. It's a dysregulation of that pathway. The pathway is overly active. So the really great thing about my job, anybody's job in this field, is that we have options. In the early 2000s and so forth, really the use of medications called mTOR inhibitors came into use. So commercially available mTOR inhibitors are out there, including names such as everolimus and sirolimus. As you'll note here, I put the trade name Afinitor everolimus, again, not an endorsement per se for the company, but just so you know that this is a commonly used medication out there. And these have been extensively tested and are, I would say, overwhelmingly considered safe and effective in the TSC population for angiomyolipoma, as well as other TSC-associated tumors. So as a rule, AMLs that are larger than 4 to 5 centimeters are more likely to have risk for further growth, symptoms, and in particular bleeding. So the international consensus guidelines from the TSC world really suggest that angiomyolipomas greater than or equal to 3 centimeters in size should actually be considered as worthwhile to treat. And the treatment of choice being everolimus at this point in time, one of the 2 available mTOR inhibitors. So everolimus, again, for the remainder of this talk, given that the data is really much more favorable for everolimus than sirolimus, I'm really going to focus on primarily everolimus for renal angiomyolipoma rather than older agents. This is a really, I think, awesome figure here from Dr. Bisler from Memphis and his team, who've really just dug into the world of renal angiomyolipoma and treatment. And what they suggest here is that use of everolimus can actually decrease the angiomyolipoma volume by up to 40 to 50%, if not more, and that longer term use confers better reduction in angiomyolipoma volume. The other thing that I think is very, very important, and we're going to continue to come back to this in the next couple of slides, is that the data appear to be very favorable for safety profile and effectiveness for angiomyolipomas, not otherwise requiring surgical intervention. So effectively using these drugs, how are we going to use them and make them work? There's a couple things that we need to think about before we start an mTOR inhibitor, such as everolimus for renal angiomyolipoma, or everolimus for any indication related to TSC. Every TSC team, I firmly believe, needs to have a really awesome clinical pharmacist associated, because our pharmacists really help us to dig into potential for interactions with your medication. So there are 2 different medication types that can actually impact how your body handles everolimus. These are called inducers or inhibitors. And really the term inducers and inhibitors are referring to how does our body metabolize a medication? How does our body actually use the drug at hand? So inducers, actually, it feels a little bit backwards, but what they do is they actually decrease the level of the drug in the blood by increasing how the body uses it. So the way I think of it is that your body is just effectively chewing through the medication so fast that the level in the blood actually is not as detectable as you would otherwise expect it to be. Common medications that this might you might see as inducers would certainly include carbamazepine, phenobarbital, phenytoin, and even steroids like prednisone. And conversely, then you have inhibitors. So inhibitors are the slow digesters. So these substances increase the level of your everolimus in the blood through slower drug metabolism. And so examples of inhibitors include antifungals, other immunosuppression medications called cyclosporin, calcium channel blockers such as verapamil, and then antibiotics like erythromycin. So as many of you are very likely aware, we could absolutely do an entire talk on the use of everolimus for TSC patient populations. I'm going to try to keep this slide sort of a 50,000 foot view and really strongly encourage folks to talk to your team about the pros and cons of everolimus for yourself or your loved one. In my experience, I have found everolimus to be very safe and easy to use. However, we do expect families at our center to keep in close contact with our team when starting the medication. And we do very clearly communicate with our families that lab surveillance or venipuncture is going to be required when starting this medication. So many of you are probably very familiar with this information, but for those that aren't, probably the most common side effects or issues associated with everolimus in particular are mouth sores, also called stomatitis. You can also see elevated blood cholesterol, triglycerides, lipids. You could see elevated blood glucose, and you could also see elevated protein in the urine. And these are all things that your team should be looking for with routine labs. Other reported side effects include something called pneumonitis, which is basically an inflammation in the lung, and general infection as well, risk for upper respiratory tract infections and so forth being a little bit higher. When you start everolimus, what we expect at our center is that we typically get labs within ideally 2 weeks after starting the medication to see how much everolimus is in the blood. And then the other thing that we'll do too is we really try to get labs every 4 to 8 weeks until a steady state dose is achieved and there's minimal side effects, and then we'll back off on labs. Before you start this medication, it's again important to talk to a pharmacist because there are certain medications that you really just shouldn't be taking with everolimus, including medications such as ACE inhibitors, because there's a higher risk of potentially life-threatening allergic reaction with the two in combination. We also strongly encourage and ask our families to make sure that their vaccines are up to date, including pneumonia vaccines and so forth. And then again, we always review other medications that may need to be adjusted or stopped prior to starting everolimus. So we'll just dip briefly into this as well. What to do for these side effects? As I mentioned before, first thing first, if you have side effects with these medications, you absolutely have to communicate with your team. And certainly the most commonly reported side effects, as we mentioned, mouth sores, lipid issues, and infection. There are multiple ways to sort of mitigate or reduce these side effects. And really, I think one of the best ways that I found is in our practice, we typically start at the lowest dose possible of everolimus and work up. The really neat thing is that my patients often will come to me and say, hey, these angiofibromas are like gone. And so we'll actually see improvement sometimes in the facial features before it really quite quickly, sometimes even before we've gotten to where we think would be a therapeutic dose of the medication. Every center is a little bit different. Within our group here, I typically target levels of approximately 3 to 5 of everolimus because I found that actually we have good response with it, but other centers may, and sometimes other centers may want to target a higher level, 5 to 8, 7 to 9. It really depends on what your doctor thinks you need. But we found that we seem to be able to do pretty well with the levels sort of in the 3 to 5, 4 to 5 range. The most common side effects, again, are mouth sores. And there's lots of little tricks that most centers know, including use of lysine as a preventative agent. You can also use like a topical steroid, swish and spit to reduce the pain from mouth sores, dental pastes, and sometimes you actually have to hold the medication for a little while. If you have lipid issues, sometimes the patient needs to actually talk about, well, maybe we need to do a little more healthy lifestyle, watch the weight, do some dietary modifications, consider fish oils or statin medications such as Lipitor. I personally, we typically follow the lipids pretty closely, but I have not typically had to intervene on these lipids for my patients at least. And we really work hard from the outset on healthy lifestyle and weight reduction if needed. Certainly, infection can happen with any immunosuppressive type therapy with which an mTOR inhibitor actually is considered. So sometimes you have to hold or reduce the medication. So mouth sores, if it becomes infected, right? And sometimes you have to actually consider antibiotics. So as I mentioned, that everolimus dosing and goal range really has to be determined by your provider. So unfortunately, sometimes medical management or a use of an mTOR inhibitor may not cut it. And I think this is a significant minority of the time. But these guidelines here, again, this is from the TSC consensus guidelines and so forth as well. Really, they're discussing that the primary approach to treatment needs to be an mTOR inhibitor. In second line, if you have a truly symptomatic angiomyolipoma, then certainly interventional therapies are often needed, such as something called embolization, or unfortunately, even in certain situations, a partial nephrectomy or a partial removal of the kidney that's actually causing trouble. But the nephrectomy topic is really needs to be approached as a team and not taken lightly, because that doesn't fix the problem at hand unless you have an emergent, obviously bleeding angiomyolipoma. Certainly, if somebody needs to have an embolization done, there's a risk for something called post-embolization syndrome, which again, Dr. Bissler from Memphis has really had nice work on this in the past, and looked at the ways to minimize risk for that post-embolization syndrome, where patients have fever and pain that can last several days, and actually found that steroids can provide a nice relief from that. The figure in the lower right here, in the panel A, you can actually see, it looks like a bush, right? Or a tree, and that's an angiomyolipoma. And then in figure B, you can just see a little bit of a squiggly fuzzy outline, but that bush is gone. And that's post-embolization, where the blood vessels are basically drawn in and obliterated. So let's talk a little bit about some real world images. Like I told you, you're going to become radiologists today. So this is a image from a patient that I followed here at the University of Iowa, and shows that when they came to my clinic, they had an angiomyolipoma of 5.5 centimeters in one of its greatest dimensions. Unfortunately, this patient had come to us with only ultrasound imaging in the past, which largely missed this angiomyolipoma. So we started everolimus, and then you can see here, there's a definite reduction in the size of the angiomyolipoma. And within 12 months of starting everolimus, we had a reduction in size down to approximately 4.5 centimeters. And then most recently, at 48 months post everolimus, the patient's angiomyolipoma was less than 3 centimeters. And that's one of those moments where you all do a happy dance together. I also wanted to just show here, this is the drug level range for this individual patient over the period of time that we treated this. And you can see really we were able to shrink down the angiomyolipoma without having excessively high drug levels. And the average level we had over this period of time was approximately a level of 6. So we've got all of these images. We're following closely and trying to minimize the risk for angiomyolipoma and treat effectively. Every so often, as a nephrologist, we get these images back and we find ourselves saying, what is the radiologist saying? And the most common thing that comes to us, and you're like, is this idea of fat poor angiomyolipoma versus renal cell carcinoma. And then the phrase that every nephrologist or any non-radiologist always dreads, clinical correlation is required. Because then you're like, well, okay, so what tools am I going to use to actually figure out, is this an angiomyolipoma or another type of kidney tumor, such as a renal cell carcinoma? So what do we do? How do we approach this? Other tumors in TSC, again, include kidney tumors that could potentially be malignant or cancerous, such as renal cell carcinomas, or other tumors called oncocytomas. And these typically occur more frequently in the TSC population than compared to non-TSC patients. In particular, these renal cell carcinomas are typically fat poor and can be very easily confused with an angiomyolipoma on imaging. So one of the first things that I'll typically do is I rally the troops. And we go and find friends. We find your radiologist that looked at the pictures. You go to an interventional radiologist and you work with your urology team, the urological oncologist, to determine the best course of action and how to appropriately take care of that finding. So as I was reviewing the data on this topic, really one of the biggest things that I found that was really helpful for me, and I'm going to save this chart for myself, is there are some loose characteristics that we can use as nephrologist or a radiologist to help sort of say, okay, this is probably an angiomyolipoma, and we can do yearly imaging, or we can treat it with an mTOR inhibitor versus another type of kidney tumor, such as a renal cell carcinoma. And different features based on how the kidney tissue looks, whether the tissue looks bright, whether the tissue looks dull, and so forth, or how does the texture of the kidney tissue itself look. So one of the things that oftentimes I've seen in the literature, and we typically will discuss here, is that we can closely follow the pictures, follow the tumors on imaging, and get a better idea of what we're actually dealing with. In particular, a diagnosis of a renal cell carcinoma needs to be considered if you see a rapidly enhancing or enlarging lesion and still no demonstrable fatty tissue. So sometimes what we might do is, if we're sort of like, well, this could be an angiomyolipoma, maybe a renal cell carcinoma, we'll recheck the images in 3 to 4 months. And then if they're stable to no volumetric increase, then we'll space the imaging out again and just continue to monitor. And usually that allows it to declare itself. Sometimes, though, unfortunately, you do have to actually bite the bullet and have a biopsy done of those lesions. That way you can actually really convincingly say, yes, this is an angiomyolipoma, treat with an mTOR inhibitor, et cetera. Those biopsies really should only be done by experienced interventional radiologists, because there is a higher bleeding risk associated with angiomyolipomas in general. So we've talked about angiomyolipoma. We've talked some about renal cell carcinoma. The other kidney findings that I wanted to talk about today, although not a tumor, are really important, are cysts. So kidney cysts and tuberous sclerosis are common. You can have large cysts, as shown on the left. You can have small cysts, as shown on the right. And really, the cystic kidney disease, or these little punctate holes, are probably the second most common kidney issue in TSC after AMLs. Cysts are reported in potentially over 50% of patients with TSC, depending on the imaging type you use. The most common cystic kidney disease are these little single or small cysts. However, larger cysts can happen in association with something that's specifically called contiguous gene deletion syndrome. So, which is a mouthful, right? This contiguous gene deletion syndrome occurs when, unfortunately, your patient, your loved one, has a deletion of 2 genes that sit back to back, the TSC2 gene and a gene called PKD1. And these genes are both on the chromosome 16. And PKD1 in isolation is associated with something called autosomal dominant polycystic kidney disease. So unfortunately, if you have both of these genes back to back knocked out, then you have both TSC and autosomal dominant polycystic kidney disease. This PKD1 gene mutation leading to cystic kidney disease is unfortunately associated with pretty severe and early cystic kidney disease in this patient population. The images here, this is actually a patient of mine that we have followed at the University of Iowa. And you can see on the kidney imaging here, you have both the cysts, the large white sac-filled structures, but also an angiomyolipoma mixed in with it. So AMLs can coexist with cysts in these patients. And then the picture on the bottom is an ultrasound, just so you had reference of what an ultrasound finding looks like in this in a cystic kidney disease patient. Many times I'll have patients ask me, well, gosh, can't we use an mTOR inhibitor for cystic kidney disease? Maybe. That's more or less what it boils down to. Depending on who you talk to and in what field, adult versus pediatric nephrology, there are very differing opinions. But one really nice study from earlier 2011 that looked at everolimus for just cystic kidneys not associated with TSC, and showed that actually everolimus could actually improve the total cyst burden in that population, although it didn't seem to impact the kidney function itself. So again, I told you we were going to talk about this, a brief detour. What's chronic kidney disease? So chronic kidney disease really is represented on the left-hand side of the screen, showing a progressive spectrum of normal function in a kidney to loss of function over time. And a lot of times you'll hear your nephrologist say, well, you're at 60% kidney function, or you're at 50% kidney function. That's a loose way for us to be able to say, help you understand kind of where your kidney disease is going and how it's progressing. Risk factors for increased or decreasing kidney function or progression of CKD include just age, having lots of angiomyolipomas, having history of recurrent embolization for those angiomyolipomas, and actually nephrectomy at any point in time. And I'll keep emphasizing this throughout the talk, but this just continues to underscore the need for regular kidney labs and urine studies to monitor for CKD early in the disease course. So one of my passions is transplant. And I could talk about transplant all day long. I could talk about TSC all day long. So you put the two together and it's a double whammy for me. So why would it on earth would a kidney transplant need to happen in a TSC patient? Why would they have kidney failure? Like we just mentioned on the last slide, historically, patients with TSC may have had more likelihood of partial nephrectomy or kidney surgeries that actually can distort and damage the tissue over time. And so sometimes our patients then, unfortunately, by nature of the kidney tissue just not being normal, will have that progressive decline in kidney function. So I've had families ask, is my patient actually eligible, or my family member eligible for a kidney transplant? And the answer is 100% yes. There are, as a whole, there's no exclusion to say that somebody that has TSC is ineligible for a transplant. There's a whole process that we have to go through to determine eligibility and medical safety with the transplant. But certainly, just like the general population, if your loved one needed to have a kidney transplant or dialysis, these things can absolutely be considered for any of our patients. One of the things that I will mention about kidney transplants in this population is that the data are divided, but some people will say that because we know there's a higher risk of kidney tumors associated with tuberous sclerosis complex, maybe when the patient gets a new kidney, the old ones actually have to come out. It depends on the center you're at and your transplant team's opinion. Here with our TSC patients, when able, we do typically take out their kidneys, the native kidneys after a transplant or at the time of transplant, just due to the risk for long-term malignancy, such as renal cell carcinoma. So how often do people need transplants in this population? So they're very limited data. Really, what we can see from the data that's been published is potentially the best guess is that between 1% to 3% of patients with TSC will require a kidney transplant in their lifetime. My team is currently looking at data from the United Network for Organ Sharing between 1987 to current to try to understand really what are the rates of kidney transplant. And we're finding about 3 per year, about 100 patients over the last 30 years, but we still have more digging to do to really understand the data. Another question that oftentimes we get asked is, can everolimus still be used after transplant? And the answer is absolutely yes, because everolimus mTOR inhibitors are a potential option for physicians as treating transplant patients. It actually provides an immunosuppressive benefit. So I have a couple of patients that are in this boat, and we've actually tried to make sure that we consider pulling in everolimus to their post-transplant care. But you do have to very clearly and carefully monitor that kidney transplant because there is a slightly higher risk for scarring within the kidney with long-term everolimus use specific to transplant patients. So I promised you the liver and the pancreas, and you've all been stuck with the kidney for the last 30 plus minutes. So the liver and pancreas and TSC, I think this slide is going to really sum up the next bit of this talk. It's like an iceberg. There is unfortunately very little published data and much likely more that probably needs to be discovered under the iceberg. So I'm really going to, unfortunately, keep this to a very 50,000 foot view because the data that's out there are largely what's called case series. Somebody reports 1 or 2 people. And so then you're really not left with a lot of ability to generalize it to the larger population. So the two studies that I really want to talk about with relationship to the pancreas and the liver are studies that actually have a decent number of patients in them. So this paper from Maury and colleagues looked at frequency, progression, and management of pancreatic tumors in TSC. So pancreatic tumors in TSC are often called PNETs, or non-functional pancreatic neuroendocrine tumors. People say non-functional because that represents the fact that these tumors are just there. They aren't actually secreting insulin or other hormones that the pancreas often can make. So they don't produce anything. As I mentioned, the literature is very limited on this topic. And this study actually was able to identify really 16 patients out of, you can see, nearly 3,000 that actually had a reported non-functional pancreatic tumor. So not much at all. And what the team here was able to really demonstrate is that the estimated frequency or rate that this happens or is detected is probably less than 1%. In the general population, that's compared to the general population, which the risk for a PNET is probably less than 0.003%. One thing that I think is really important to consider is that this paper actually really emphasized that these tumors may actually be underreported in TSC because radiologists are usually doing what we ask them to. They're usually looking for the angiomyolipomas, and the pancreatic tumors may not always be the first thing that comes to mind when the images are being reviewed. So these pictures here show you the area of brightness and the panels here, which is that pancreatic tumor. The majority of the time, these are also thought to be very responsive to everolimus and largely asymptomatic in nature. So likely less of an issue than an angiomyolipoma. And the liver tumors in TSC, when we talk about liver pathology, they're most likely to actually find angiomyolipomas in the liver. Your radiologist might also call them hamartomas. And you can also find liver cysts in TSC patients as well. One paper by Black and colleagues actually looked at radiographic or MRI and CT pictures for over 200 patients with TSC to try to figure out how often do these liver cysts or angiomyolipomas pop up. Within this cohort of 200 patients, they found that actually within 30% of the cohort, these hepatic angiomyolipomas or cysts actually showed up. The majority of the time, these were asymptomatic and did not require any actual treatment. And actually, in line with that, most likely, if you have a hepatic angiomyolipoma, you're probably also going to have a renal angiomyolipoma. So hopefully you're being treated for the renal AML, and that's protecting the liver as well. The risk for these lesions, as with the pancreas, comes with a TSC2 gene mutation, older age, and again, the findings of renal AML. As with the pancreas, none of the patients in the cohort had clinically significant symptoms or complications from their hepatic lesions. So really, I think at the end of the day, the reason I'm able to boil the pancreas and the liver down to 2 slides is that compared to the kidney, they don't have the complications that we see with kidney, and they typically don't have the symptoms we see with kidney tumors either. So that certainly leads us to sort of closing around home to sort of be able to talk about questions at the end. So this field is ripe for research and educational opportunities. Maybe there are better ways or protocols to detect liver and pancreatic tumors. How do we educate radiologists and our peers in the medical world about TSC-associated tumors that maybe otherwise wouldn't pop up on the radar? And one of the things that I think is actually really important in my world is, what is the actual risk for end-stage kidney disease, something needing dialysis or transplant in this population? Really, hopefully, this has become very clear that these are things we just don't have good data for right now. So take-home points today: kidney tumors are common in the TSC population. They can occur early in life and unfortunately lead to premature death. Abdominal imaging is critical. mTOR inhibitors such as everolimus are safe and effective for abdominal tumors. And unfortunately, again, as we just mentioned, there's a significant gap in the literature about the liver and pancreas tumors associated with TSC, and a really major research opportunity. So I'm going to come back to the slide in a second, but again, I really thank you all for inviting me here today. I really am delighted to be able to talk on this this topic. This is our team here at the University of Iowa, and we love what we do. And I'm really blessed to have these coworkers and that we are able to care for our kids with TSC. So I'm happy to take questions, but things that I would love to be able to just get information and pick your brain on. What part of your nephrology management do you wish you would have known about earlier? And how could a nephrologist such as myself better educate patients and families about TSC related complications? So think about these questions. What do you wish you would have known? What could we do better? And I'm going to stop my screen share and I'm going to open up for questions and go from there. So thank you.
Thank you so much. That was just a fantastic presentation. We've received a lot of questions in the chat log, so I think we will have time to get through a couple of them, and then hopefully we can send you the others.
Absolutely, yeah.
Great. So I'm going to get to the first couple of them, and the first one being, my son has no mutations but kidney cysts and AMLs. Should we repeat the genetic testing?
That's a great question. That's again a primary question that you definitely need to talk to your team about. And sometimes too, if you don't have an actual TSC diagnosis by gene testing, but you have a clinical diagnosis, then to my understanding too, sometimes there are different gene variants that are able to come into the testing panels that we have available. And so our team continues to just reevaluate whether or not that gene testing is actually accurate and helpful. You could also discuss with your team and the genetic counselor whether or not a kidney specific gene panel is useful. And there are some really amazing gene testing panels for kidneys out there too, to talk about what's going on.
Thank you. The next question, our son has TSC2 and ADPKD. We're being closely monitored, and recently the protein in his urine has been increased. Recently, the protein in his urine has been increased, but his creatinine and other labs are stable. He has no AMLs to date, but has many simple cysts and very large kidneys. He's on several blood pressure medications. Is it possible to predict with some certainty when our son will need a kidney transplant?
You have an amazing team at Stanford. Their pediatric nephrology group is excellent. So you are in amazing hands. The protein component, so we use a ratio called a urine protein to creatinine ratio. And basically a ratio number less than 0.2 is normal. Most of the time we'll tolerate a ratio of 0.2 to 0.5, but anything above 0.5, we start getting a little bit like antsy about, and working with blood pressure medications, in particular medications such as ARBs like losartan or ACEs like lisinopril. So certainly talking with your team and making sure hey, is there a better way we could adjust these medications to work with his proteinuria? Those questions are things I empower you to ask about at your visits. And certainly sometimes it can be optimized, but sometimes, unfortunately, despite our optimization, they just are keeping the proteinuria at bay, which is frustrating. There are a couple of calculators out there. There's a calculator you can find online called a kidney disease progression or kidney risk progression calculator. And basically with that, your team, which I know the Stanford team knows about this calculator, they can plug in basic information about the kidney disease, the proteinuria, the creatinine, and give a general 5-year risk for transplant. And the calculator is thought to be pretty darn effective and pretty accurate.
Thank you. I think that we're out of time. We will follow up and send you the remainder of the questions, Absolutely. Dr. Harshman, and maybe there's a way for us to distribute the questions that you asked of the audience so that you could receive their responses. So with that, I'd like to say thank you, Lindsay, for providing great information. We appreciate all of your time and expertise. And thank you all for participating today. Thank you again to our presenting sponsors of the 2021 eWebinar series, Greenwich Biosciences and our national support sponsors, UCB Inc. and Novartis. The Life Stages webinar is sponsored by LivaNova, Lundbeck, Mallinckrodt, Neurelis, and Upshur Smith Laboratories. To register for future webinar topics and access recordings, please visit tscalliance.org/e-webinars. Thank you all.